Oh, great. Well, first of all, thank you very much for the invitation. And this is a very kind invitation. And as said before, I'm Ana Maldonado Contreras. I'm an assistant professor at the University of Massachusetts, Chan Medical School. And I'm also the co-founder for the Center for Microbiome Research here at the university. My laboratory focuses mostly in microbiology, understanding how bacteria interact with the host cells and how that causes a perpetuation of inflammation in inflammatory bowel disease patients. And we use a way to manipulate this gut bacteria or the microbiome through diet. And today I want to give you just a little bit of an overview of where we stand about nutrition as therapy for IBD. So I think earlier in the talks, somebody asked about what Egypt should be investing in research. And I agree, combinatory therapy is the way to go. And I hope that I convince you that also within this combination of therapy, you could include nutrition as part of the treatment for patients with inflammatory bowel disease. We're very excited in our field because finally nutrition is being accepted as part of the treatment. And there is exciting research that points at very robust relation between foods and symptoms. And I'm going to talk to you about several clinical trials, randomized clinical trial, very rigorous and with a lot of people involved and recruited with power clinical trials that demonstrate that from kids, from pediatrics IBD to adult IBD. And I'm going to show you some, as I said, some are already published studies. I'm also going to show you some of our studies here at UMass that are about to be published. So these are not published data, and I'm going to do that. So the first study that I want to talk to you about is we start with kids. So there is this study that it was a multi-center study led by Ari Levine in Israel, and they recruited pediatric patients with IBD and actually with Crohn's disease specifically, and that then test them different diets, two diets, one that they have created called the Crohn's disease exclusion diet, combined with partial enteral nutrition. So there's already been research on an exclusive enteral nutrition and how treatment of pediatric patients with EEN can ameliorate and achieve, the kids can achieve remission very rapidly. But this is a diet that is hard to follow, it's hard to prescribe. So in this group of researchers are trying to understand if including the exclusion diet that is still a whole food diet, but it has no animal. I'm putting here on the left. Let me see if I can do this. Can you see my laser? So here is a brief description of what this diet is about. It avoids animal unsaturated fats, milk, fat, gluten, and emulsifier, red and processed meat, and include a variety of fruits and vegetables. That this whole food diet can be combined with a formula, or the liquid formula of the enteral nutrition. So, and then they have a randomized group of kids that only receive exclusive enteral diet, or EEN. And those are a liquid formula. So the study was, after these are the exclusion and inclusion criteria, kids were having mild to severe disease, to moderate disease, Crohn's disease, and they have a stable therapy. So the only differences between before and after in the study was the inclusion of the dietary treatment. Kids were randomized into two groups, one that have the CDED, or the exclusion diet, plus a 50% liquid and partial enteral nutrition, and then a washout period, and then they go on a second phase where there is most of the whole food and less of the liquid diet. And that was compared with a group of patients that have in the first 6 weeks exclusive enteric diet, or then 25 of the enteric, it will be partial enteric nutrition or diet plus free diet. They compared two groups. They assessed the first primary outcome was remission and in these patients. And so they observed that at 3 weeks, and actually through 6 weeks, all the participants exhibit response to either diet and achieve diet remission. So here I highlighted in yellow the primary outcomes for this study, and we get like close to 83 and 85% of the patients in week 3 or week 6 response to the diet, show response to the diet measured by this pediatric Crohn's disease activity index, and the decrease of 12 points was the cutoff for this outcome. And then remission, that is a PCDA of less than 10, was achieved by up to 67% of the patients. Then they measure fecal calprotectin and normal fecal calprotectin below 250, and they observe that patients, again, pediatric patients, 46 and 48%, achieve these normal levels of fecal calprotectin after 3 and 6 weeks of the diet. So I'm sure you can realize the efficacy and the rapid effect of the diet. We're seeing response even at 3 weeks post-intervention. And then they evaluated the response at 12 weeks, and it was pretty similar. And actually, in a univariate analysis, they found that patients that achieve remission at week 3 were mostly have higher proportions having it was a predictor of having in remission in week 6 and also in week 12. There was no difference between the two diets in terms of remission response and fecal calprotectin reduction. So in either diet, patients seem to be responding at similar levels, like 80% of the patients response to the diet. But again, as diet can be customized and depending on the circumstances of the patient, if you want to include more compliance to the diet, perhaps the combination with the exclusive diet plus the partial enteral nutrition is a way to combine with the therapy, that ongoing therapy for pediatric patients with inflammatory, in this case with Crohn's disease. So the next study is now with adults, and this was also recently published. And this is a group from University of Pennsylvania, led by Dr. Lewis, and they also did a randomized trial, and they compared two diets. In this case was the Mediterranean diet and the specific carbohydrate diet. Both of those diets have been studied in IBD and being shown some important progression of the patient, but this was like a robust, very robust, multi-center study clinical trial. So here just at the consort diagram, they actually have they screened over 400 people, and then at the end, you can read a little bit more in detail of that. But at the end, they got 92 patients in the arm with the Mediterranean diet, and 94, if I don't remember, we're seeing in the next slide, on the specific carbohydrate diet. And this is in a nutshell what the diet is about. The Mediterranean diet allows all fruits and vegetables, is very low on red meat, and then encourage the eating of fish, olive oil as the main sources of fatty acids. There is no added sugar, and there is no processed foods. In the specific carbohydrate diets, all fruits are also included. Certain vegetables are included, the non-starchy vegetables preferentially. All red meats are allowed, just lean. All fat oils are allowed. Milk and grains are not permitted, and there is no processed food in either of them. So using either of those diet, at week 6, it was the primary outcome measurement. Participant reported remission and fecal calprotectin response. So here I'm showing, this is in yellow, I'm highlighting the primary outcome. Symptomatic remission was achieved in up to 46% of the patients in the specific carbohydrate diet and 43% in the Mediterranean diet, and there's not much difference between the two of them. And then we see fecal calprotectin response. There is not much of CRP response on these patients. But again, half of the patients seems to be responded to the diet. And then at week 12, we see the same amount of patients responding to the diet, symptomatic remission and fecal calprotectin remission. And just a little bit of all those previous studies has been done in patients with Crohn's disease. This is a very small study. It was randomized, but not completely powered. And this was with patients that actually are in remission. And these researchers in Florida compare the improved standard American diet and the low-fat, high-fiber diet. And the difference between those two is where the percentage of calories from fat come from, and the amount of fiber that the patients receive. I'm not going to go into details because I see that I just only have 4 minutes, but in all of the cases, and I think it was eight patients per group, and it was a crossover study. The low-fat diet seems to, and in the improved standard diet, both of them have lower the disease activity in patients with ulcerative colitis, increase the quality of life measured by the short IBD questionnaire. And again, this is the SF36 questionnaire that also measure quality of life in different areas like emotional and social functioning. But importantly, they saw that the low-fat diet decreased significantly fecal calprotectin, C-reactive protein, and serum amyloid A on these patients. So there is a change on the immune response on these patients to lower the immune response on activity in these patients with ulcerative colitis. I'm just going to, in the last 3 minutes, talk a little bit about the study that I'm leading here at UMass. Again, we are just processing the data and about to publish. We have also, it wasn't a clinical trial, it was a prospective study where patients were used as their own control. Our hypothesis is that diet can change the gut microbiota, and that is what helps lower inflammation, restore epithelial integrity. And so we were testing that. Can the diet change bacteria can be correlated with improvement of symptoms and improvement of epithelial inflammation. So the diet, we created also a diet, and at this point, I hope the take-home message is like, it doesn't matter which diet, but including fiber through prebiotics, fruits and vegetables. And in our case, we also include honey and oats. And also what is unique about our diet is that we include probiotics and fermented foods, basically, and then including monosaturated fatty acids, reducing the saturated fatty acid, only lean animal protein or vegetable protein, and in adverse food, the same that the Mediterranean diet and the carbohydrate restricted diet propose are the ones that we also use in our diet. We have preliminaries, we have a previous study where we showed that this diet actually helped. It reduces the activity score of patients with Crohn's disease after 4 weeks on the diet. This is 8 patients with Crohn's disease and 2 patients with ulcerative colitis. In this study, we saw that after 10 weeks on the diet, patients in general show a lower of decrease on interleukin-8, which is a potent inflammatory cytokine, and then an increase of the GM-CSF factor that has actually been associated, increase has been associated with reduce of IBD pathogenesis. We see a response in 50% of the patients. This is a self-reported response. And some of the patients don't have any response to the diet, and only 3 have a negative response to the diet, and in most of them were not compliant to the diet, as shown on the other studies. I didn't say that, and also have another non-IBD related diseases. Some preliminary analysis of the fecal stool from these patients have shown that fecal calprotectin dramatically reduces after the diet. So I'm going to skip. We have done microbiome analysis and see striking differences between patients that before and after the diet, and mostly recovering dysbiosis and the bacteria that are related to this dysbiosis in IBD patients across the world is being favored by the bacteria. So the take-home message is that diet works. And there is a lot of commonalities between the diets that I just described, increasing consumption of fruits and vegetables, and which mean fiber, reduction of elimination of processed foods, reduction of elimination of sugar intake, reduction of animal protein, and moving more into vegetable protein, increase of the fiber consumption, and decrease of reduction of saturated fat, and modifying those fatty acids to include actually monosaturated fat that are more related with anti-inflammatory responses. So I leave it up to here if there's any questions.
Thank you, Anna, for this cheap treatment. Any questions?
If you don't mind, I just have a very short comment. Is that allowed?
Dr. Ines.
Aywa. Dr. Anna, thank you so much. Such a nice and precise talk about the nutrition support among patients with Crohn's disease or inflammatory bowel disease in general. I just want to add a small comment over here based on some experience here in Egypt. Using the exclusive enteral nutrition in children was actually very effective, especially during the induction therapy period. I don't know if you would agree on that or not. And I have a second question. Do you ever utilize things like antioxidants and omega-3 as a recommendation mandatorily added to your protocols in clinical nutrition with inflammatory bowel disease? And thank you.
Yeah, thank you for that. So we haven't tried, well, I have to say, I'm not a clinician. I'm the one in the microscope behind the bench. Mm-hmm. But I have my collaborators in nutrition. Our clinic mostly see adult patients, I have to say. So our experience with children is very limited, but there is increasing evidence that EEN is effective for children to induce remission. That's no question about it. So I will completely agree. I think where we're trying to move the needle forward is just what next? When you send the patient home, what do you do? What do they eat? Because that's what we're trying to understand, which foods are better to keep continuing eating than when you're home, and face it, some patients are very scared of fruits and vegetables because there's too much fiber. So at which stage do we give them the fiber? And that's also that's very important for our studies to understand these phases that patients have to go until they're in full remission. And even when they're there, what to eat. And your other question was about, sorry, you say, I missed it. I have the response, but I missed it. I forgot.
It was about the omega-3 and the antioxidants. Oh, yeah. Kind of add them, as a recommendation or not? Yeah.
Oh, in our diets, we use a lot of nuts and seeds as omega-3 supplements. So we recommend the patients to eat hemp seeds, chia seeds, with their yogurt, with their smoothies, etc. So mostly to increase the consumption of omega-3 fatty acids.
But would you agree that, I'm sorry, I didn't mean to interrupt you, but all patients, no matter what, if they're in an active stage, they're going to end up, even if they start on an exclusive enteral nutrition, they will end up going back to their regular diet. Do you think that eating nuts per se, as nuts, do you think it's going to be kind of okay with those patients, especially when we're kind of in a transition period between one active stage going into the other stage?
Yeah, it should definitely be okay. And our diet, we actually, one of the things that we do that is different from other diets and also encourage you to do that is that we actually teach the patients how to cook. Where you go home, how do you cook these foods, right? Because that's the big deal. How do you recognize this food in the supermarket? Mm-hmm. And now in food is very cultural and it's very attached to where do you grow up. So we're trying to understand these really interactions between, is it carrots that triggers this bacteria or favors this bacteria that then causes inflammation. So if it's carrots, what is it about the carrots? So when we move to Egypt, for example, then you guys don't like carrots, but then there is something that have the same content. Just an example. But just to understanding that interaction will help us to contextualize diet to different culture.
Sure, thank you.
Thank you, Anna. Thank you, Anna. And we have to move for the next speaker.